Okay, next speaker.
Next speaker, it's my pleasure to introduce you Dr. Bassel Zebian from UK, and he will talk about endoscopic approaches to intraventricular tumors. Please, I leave you the stage.
Thank you very much. Thank you, Mehmet, for the invitation. It's not easy to follow two excellent colleagues who have summarized intraventricular anatomy and their experience with intraventricular tumors. It's a pleasure and an honor to discuss my experience and our experience at King's on intraventricular tumors. I'll be talking mainly about endoscopy, but there is a bit of a disclaimer. I don't use endoscopy only for all my intraventricular tumors, and I'll explain. So I'm a pediatric and adult neurosurgeon. I hope you can see my slides. If you can't, please tell me. My declaration of interest is that we run yearly courses and they're sponsored by industry. So the objectives really of my talk is why endoscopy and where, how, a little bit about the literature, our own case series, but specifically, it's not all our intraventricular endoscopic tumors or intraventricular tumors, but the endoscopic ultrasound use and the transchoroid approach, some examples and the future. So why endoscopy? We all know it's minimally invasive, improved visualization, speed of access. So the minute you put an endoscope in the ventricle, you see a tumor. And it's easy to confirm that you've taken out a whole tumor with the endoscope, as long as the tumor is small. On the other hand, the learning curve is quite steep. Length of procedure can be quite long, although admittedly, I'm perhaps the opposite of Professor Goel in some of my approaches. Yesterday, we managed a brainstem cavernoma in 2.5 hours, but at times I am operating longer than 12 hours. But some of the patients I operate on are a few months old with really big tumors, and I think if we rush a little, then we lose too much blood and they won't make it through an operation. Hemostasis is key, which was always very difficult. Instrumentation is difficult as well with the endoscopic approach. And it's very difficult to confirm the extent of resection with large lesions. So although it's easier with smaller lesions, it's more difficult with the bigger ones. So again, as I said, not all tumors in the ventricles are endoscopic targets. This is a brainstem tumor. A lot of what I do is fourth ventricular tumor resections. This was a pilocytic astrocytoma that had been growing, and the way we approached it was a traditional microscopic approach. So just so that we are very clear, we're not saying it's endoscopy for every single intraventricular tumor, or endoscopy for the sake of endoscopy, or endoscopy because, you know, we're a team with a hammer and everything looks like a nail. So an operation such as this one, I'll scroll through it a little bit quicker. You're trying to expose the floor of the third ventricle to go into the floor in what we call safe entry zone. In a way, I'm not sure the safest entry zone into the brainstem is not to enter it at all, but there are ones that are better than others to choose. And here we use monitoring, we used various adjuncts to be able to go just above the facial colliculus and go into the tumor. And the outcome was rather satisfactory. We still left a little behind, and the idea was that if it grew, we would give adjuvant therapy. We moved away from proton for these, and we give zinc and carb. So we reestablished CSF pathways. The patient had not developed hydrocephalus. So for something like this, I would never have even thought that an endoscopic approach is the best way. I did use the endoscope at the end to look around the cavity, but that's not really endoscopic surgery. So just a few examples here of some of the work that we had been doing endoscopically. It's a bit of a perhaps intense slide there, but it shows you the intraventricular work at the top left. And that's a really big cyst, which is sella suprasella, that we managed with the endoscopic approach. Then on the right, you can see our fetal endoscopic approaches now to spina bifida. I won't go into the ins and outs of why operating at the fetal stage is important and why it's indicated in some patients, but certainly the MOMS trial had answered a lot of these questions, and we do a lot of this endoscopically. And at the bottom is actually a more recent kind of a journey that we started, which is using biportal unilateral endoscopic approaches to spinal stenosis. This or any kind of degenerative disease of the spine. At the moment, just for the lumbar spine, although I think soon we'll probably be looking at thoracic and cervical. So this is really the background for us. This is where we had come from in terms of the endoscopic approaches that we were able to offer. Where it all started for me was actually quite a bad endoscope, although I was quite disappointed when Medtronic stopped making it. But the visualization was quite bad and poor, and the instrumentation was poor. It was really good that they stopped making the endoscope, because it meant
one of our theaters, as I said, not the one.
It meant that we could then start using better endoscopes with better optics, with better channels. What you saw earlier is just a short clip of the setup that we have for endoscopic operations. When we're doing big tumors, it's the Invent endoscope at the bottom that we use. It's an 8.3 millimeter outer diameter. That's still quite small. That's smaller than most tubular retractors. I do also use tubular retractors, particularly the Vicor retractors. The internal diameter is 3.7 by 6.5, which allows us to move instruments inside in a slightly easier way than, let's say, round channels. Also, you can do by manual manipulation. For a lot of tumors, colloid cysts, for instance, I only do endoscopically now, and I use the Minop intraventricular scope, which is the one at the top on the left. In terms of the instrumentations, the coagulation is key and has allowed us to do a huge amount. But also these instruments that you can rotate, where you can take a bite and keep, it's called a spaghetti maneuver. Some of us who perform a lot of these operations have termed it that. So these instruments are really useful. And what you can see at the bottom is the sucker. I don't use a syringe. I just couple it with the wall-mounted suction, and I use it as I would with a microscopic approach. About 10 years ago, we were looking to try and make endoscopic surgery as close to microscopic surgery. We found an endoscopic ultrasonic aspirator, and it was very much like Christmas. Except when it came, we realized it didn't fit down the Invent endoscope. This is what it looks like. The three-way tap is unnecessary because you do not need to wash and suck at the same time. All you need is suction. But it's nice to graduate the suction. We've modified it a little bit to allow us to do that. So what we did at the time is we've taken the titanium sheath off and the green stopper that allows it to fit to the Gabb scope. Unfortunately, Professor Gabb passed away not long ago, but had developed an excellent scope, although we had moved on since then. Since then, we've published our, I believe, the largest case series of endoscopic ultrasonic aspirator use to allow resection of some intraventricular tumors, and I will talk about the case series a little bit later in the talk. But here's the abstract. So what the company Soaring had done since then, based on a lot of the work that we had done and other colleagues in Germany, is that they have moved away from the old sheath to the new titanium sheath that actually allows you to put it down the Invent endoscope, because most people are now using the Invent endoscope, and certainly in Europe, because of the lack of CE marking for some of the Storz scopes, I think more and more people are moving towards Oscilab. So what we did in terms of the recent development is we just put the graduated thumb suction piece onto the Soaring aspirator, and we've used it in that context, because then you can actually use it as a real sucker, as well as and in the traditional suction type of way, but as well as using it as an ultrasonic aspirator. Some more recent developments is intraoperative neuromonitoring probes that we developed at King's to allow us to replicate essentially what we would do with microscopic approaches. And we have been able to accurately detect where the internal capsule would be and how far from our approaches. Just some alternatives to the aspirator. We have the debriders, Nicomyriad, as well as the Penumbra. Both have initially been investigated in the context of intracerebral hematomas, but really the papers just say that for select patients, taking out the intracerebral hematoma is a good thing, rather than you must use the Nicomyriad or the Penumbra. It's really important that they're prohibitive in a lot of countries because they cost a few £1,000s per hit. That's not even the hardware that you have to buy at the beginning. But I think there is some role in using those. So in terms of our own endoscopic ultrasonic aspirator case series. So that's not our intraventricular tumors. That's just when we used ultrasonic aspirators. I think we're now on around 100 or more intraventricular tumors. We'll be looking at all our numbers very soon, publish them. That's not counting the ones, of course, that we did endoscopic assisted or mainly microscopic with a bit of endoscopic. So it's 52 patients up to June 2022. The majority had ventriculomegaly. It was 58 procedures, useful in over half of the patients. I think in the majority, just the suction was enough. Gross total or near total resection in 30%. The reason for that is a lot of what I operate on is a low-grade glioma, i.e. an optic pathway hypothalamic glioma. You're not going to take the whole tumor out, or a craniopharyngioma, for instance. Other tumors are probably more amenable to gross total resection. 40% had splitting of the choroid fissure. No adverse events long-term related to any of the use of the ultrasonic aspirator or these procedures, and we had no deaths either. So the factors that really facilitate a more complete resection are location, consistency, histology, as well as instrumentation. I was under the impression most of my tumors were going to be lateral ventricular, but actually the majority are third ventricular, pineal, thalamic, tectal, midbrain, and so on. And that's just a little bit of a diagram just to show you, and a pie chart to show you the patients that we've operated on. So in terms of looking at the examples, the first patient that we used the ultrasonic aspirator on was an 86-year-old lady who was swimming 4 times a week. Was quite well, but she had some cognitive decline and a little bit of instability, and she had hydrocephalus. The idea was to go in, take a sample, do a septum pellucidotomy, and shunt her and send her off for adjuvant therapy. As we went in, we had the ultrasonic aspirator. We thought, let's just try and see if we can at least just take some bulk of tumor out. And lo and behold, we were able to actually take a fair amount of the tumor and open up the posterior aspect of the third ventricle. And I will show you that now, if I can do this. There we are. So we de-roofed the top of the tumor, and that was all that was necessary, and we re-established CSF pathways. At 86, she survived till she was 89 and then passed away of unrelated causes. Now, the opposite end of the spectrum, a 2-year-old with a relatively sizable meningioma. I was convinced this was another choroid plexus papilloma, so when I approached it, I thought I'd approach it, get to the stalk, and coagulate it, cut it, and then everything would be devascularized and the whole thing would pull out. Of course, it was stuck to everything. It was a meningioma. It wasn't a choroid plexus papilloma. We were able to get to the stalk. We were able to use bimanual manipulation. We pulled it up. We cut the stalk, but it was still an operation that required a fair amount of time. We had to stage it, and I did use tubular retractors. You can see the soaring aspirator used there, although it looks like it's sucking up a fair amount, but actually it's kind of almost the Eiffel Tower type of phenomenon. You're really up close to the tower, and everyone keeps asking you, how beautiful is it? And you can't see it. And you're very close, and you think you're doing a huge amount of work, but actually it's very small, the amount that you do it. And that probably means that you just overestimate not only the amount of resection sometimes when they're really large, but also any effects on the brain nearby. So you protect the brain more by using the endoscopic approach sometimes. So even with the tubular retractor, the vocal retractor there, it was a bit tricky because it was stuck to everything. So after staged surgery, I'm pleased to say that we actually were able to get a good result after the first emergency operation. It was only a small amount that we took out. The child was quite young, so we didn't wish to rush it, and then we went back in and took it out with using the tubular retractor. And actually, the approach and the corridor was quite small. And since then, she's been fine. It's been quite a few years. Another example is an exophytic thalamic tumor into the third ventricle. This was a glioblastoma in a 14-year-old. Generally speaking, the survival is dismal, and it's less than 3 months in a lot of them. We were quite fortunate in that we were able to debulk the majority of it. And then the child underwent 2 further operations over a period of 24 months. So we had 24 months survival, good quality of life, able to go to school. Any weakness had always resolved. So whenever he'd present with when he operate, the weakness. You can see the posterior aspect of the third ventricle there, with the aqueduct, with the habenelli commissure and the pineal recess in between, and the roof of the third. I did stent the aqueduct in this situation because I was convinced that there's going to be a recurrence that would block the aqueduct again. And indeed, there was a recurrence, but actually we had to go back in and resect more anyway, in any case. So now just moving on to the transchoroid approach. I did mention the transchoroid approach, and that's more or less the final part of my talk. The transchoroid approach is really to allow us to get better access to the third ventricle. My approach to, let's say, pioneer tumors is usually infratentorial, supracerebellar, microscopic, and endoscopic assisted. But at the very beginning, when patients come in, we often did endoscopic third ventriculostomies, and occasionally we're able to get biopsies. So the reason for the transchoroid approach was mainly pineal tumors and how they looked at on the scans. And I was convinced that had I had access through the choroid fissure, I would be able to do much more. So I'll talk to you about the available literature, the anatomy technique, and some of our results. So as we said, the majority of pineal tumors will come in with hydrocephalus. ETV is now recognized to deal with the hydrocephalus. I know lots of people say, stop worrying about it, just put a shunt in. But the reality is we're no longer in that era. We know that there are a lot of complications that can happen with shunts, and we know that we can do more endoscopically. I am not saying that I don't shunt plenty of patients, but I certainly shunt a lot less than I did before. So ETV is recognized, and at the same time, it gives you access to the pineal tumor. The pathology is diverse, and tumor markers are not enough most of the time to guide you, so a biopsy is quite useful. The question is, would we be able to resect using that approach? The limiting factors with the foramen of Monro is small, trajectory is quite an issue, and some people will talk about using 2 burr holes. So what we looked at was one of the first papers that I could find was from Professor Roton and the team, and it was a cadaveric approach. Following that, there was in 2005 a publication, a microscopic video of a transcallosal transchoroid approach. Then my colleague and friend from Spain, Professor Ibanez Botella, who had described 7 endoscopic transventricular transchoroid colloids. And since then, there'd been a fair number of publications, perhaps 4 or 5, which all describe various numbers of transchoroid approaches. And the transchoroid approach, there's 2 different types, either intraforaminal or extraforaminal. And now I use the intraforaminal approaches for the anterior aspect of the third ventricle and the extraforaminal for the posterior aspect. So in the same publication that I mentioned earlier, we also covered our transchoroid approaches. The transchoroid approach, basically you coagulate the choroid plexus and you will go through either the taenia fornicis or taenia thalami and the telechoroidea. What you have is the internal cerebral vein, and you have to push it to one side or the other, and it all depends on what it looks like on high-resolution imaging that you have to examine at length pre-op. This is from Professor Roton, and I wish it all looked like, because life would be so much easier, but of course you do your best to make it look as close to that. The first patient was a gentleman who had a PhD in neuroscience, so perhaps a lot more pressure than it needed to be. But the reason I did think that this was the best one to try was because of the way it looked on the coronal, and it looked like you could see it from the lateral ventricle. So what you see here is our first patient, and we made a small hole, but actually I was doing it all wrong at that stage. I should have coagulated the choroid plexus and lifted the fornix, which I hadn't done. The patient did really well, but we only could get the biopsy from within the foramen of Monro. Then a little down the line, we had a patient with an assisted fourth ventricle and a blocked shunt. And this is where the transchoroid approach started working. You can see both fornices. You can't see a septum. The anatomy is distorted. And I couldn't get into the third except by splitting the choroid fissure. And the foramen of Monro completely stenosed. So this is really the first patient where really the transchoroid approach worked quite well for us. And I'll go a little bit further down the line because the idea is to show you the use of the transchoroid approach for tumors. So this allowed us to get a stent in. The stent is tethered with a reservoir at the top of the head, and then the assisted fourth ventricle was treated, and we actually also managed an ETV, and we didn't have to worry about the shunt after that. So then when it comes to tumors, anterior third ventricle, colloid cyst, and optic pathway hypothalamic gliomas, as well as craniopharyngiomas are ideal candidates. This is a papillary craniopharyngioma. Just a couple of pictures to show you coagulation of the anterior septal vein, cutting the septal vein, and then you end up with this comma-shaped kind of foramen, and then you can take a lot more of the tumor out. So this was a near total resection. Patient survived for quite a few years, and then the tumor grew. We gave radiotherapy later down the line. Our experience of colloid cysts, the numbers are far less than Professor Goel's numbers. We're on 25 or 30 now, but all of them have been endoscopic. This was the first one I did as a consultant. It was quite a challenging one. It was going between the leaflets of the septum pellucidum. And you can see the bulge there just beneath the fornix. So it's a matter of coagulating, getting the content, but also removing the cyst. I've never had any long-lasting memory deficits, but we've not had any recurrences so far in the last 10 years. So I think it's quite a useful approach. At this stage, I wasn't splitting the fissure, so it was much more tricky, and it was more about pulling and doing the spaghetti maneuver as much as one can do. And then you can see a gross total resection, and the trajectory you can normally hardly see post-operatively. So this moves us on to more or less the final few patients in the talk. And this is an optic pathophytic glioma, a 10-year-old. This patient, you're not going in to resect the tumor, but she progressed on 3 lines of chemotherapy. We didn't have any pathology. So the hydrocephalus was becoming an issue. So the idea was to go in. I always do a septum pellucidotomy because the wash can go to the other side and collapse the ventricles onto you. So septum pellucidotomy, and then we go back to, we're on the left lateral. I don't always go on the right. I don't always think of coccus point or anything like that. I just go by trajectories and I measure. That was the intraoperative neuromonitoring probe that we used. I used it on the caudate, but the caudate never brings back really any stimulation. Normally it's the floor of the lateral ventricle. This is coagulating the anterior septal vein. We cut that, and then what we do is we dissect the tumor a little bit from the superior aspect of the walls of the third ventricle. You don't do that when it's deep down because you're going to cause trouble. And then this is the suction, not the endoscopic ultrasonic aspirator. We open the back of the third ventricle, and you'll see, as you did with the glioblastoma earlier, that you can then identify the aqueduct, you can identify the tectal plate, the habenulocomissure, and the pineal recess. And all we did was this. And I was patting myself on the back thinking, this is great. If chemo can only hold it, so we at least took some pressure off. We reopened the pathways and so on. Let's see, I might have to go back in another time to take more out. Of course, what they did is they found a target, and with targeted therapies, it turns out that they are the heroes of this story, not us and not anyone else. So actually a lot to say for targeted therapies in the future. So then moving on to posterior third ventricle, this is one of the first ones we did. And that's, again, I went from anteriorly, so intraforaminal, but that's probably because we hadn't quite developed a posterior extraforaminal approach. That's the tinea fornicis, and we lift those up. And what I will show you is just what it looks like inside. We can just miss the endoscopic third ventriculostomy. That's the fornix being lifted off. And it's a bit of traction to go in anteriorly and move towards the pineal recess, but there we are. That's the pineal tumor there. The massa intermedia, you can divide. We described that before. If it's a very long and thin and thready massa intermedia, not if it's kissing thalami, that would be a mistake, and that would cause major trouble. So that one we did not take out, and we had to go back in with a posterior approach. But since then, we've had our first patient where we manage a complete resection from an extraforaminal transchoroid approach, the posterior aspect of the third ventricle. And I'd like to just show you that briefly. And that's the fornix just being lifted off the thalamus, the internal cerebral vein that you can see there. Now, I do take a fair amount of time kind of operating, but not with these. This was about 3 or 4 hours and allowed us a complete resection. And you have to mobilize, as Professor Goel was saying, you have to just make sure you create the corridors and either retract. It's a bit tricky to retract with endoscopic approaches, but you need to make sure that once you have done the dissection, that you're able to kind of so the biggest challenge is often getting the tumor out because you've got the small approaches that you've created in small corridors. And essentially, post-operatively, that's what we had. And then after a period of 2 or 3 months, we realized we were worried about residual, but actually it was just post-operative changes. So this is our transchoroid approach so far. This is up to 2020. We had data for 41 patients, but we operated on 81 patients and 82 procedures. We're on a fair amount more than that since then. Majority were astrocytomas or craniopharyngiomas, and no major complication related to the approach. We did cognitive testing for many of them, but not all. But hopefully soon, by the time we publish, we'll have all the data ready. So endoscopy of intraventricular tumors, in kind of conclusion, is not for all tumors, but it is an essential skill. I think if you're operating inside the ventricles, you should be able to use an endoscope, and perhaps you should be someone who doesn't just do an endoscopic third ventriculostomy, but someone who's able to also resect tumors. Patient selection is key. Imaging is key as well. Flow sequences and high resolution sequences are really useful, if not essential. The surgical setup is very important. The team is very important. Navigation is very useful, but don't just count on navigation. You should be able to do it even without navigation, but navigation itself helps you to do that because it gives you a better 3D picture of the anatomy. MDT discussions, of course, and fora for discussing complex cases are really useful, as well as courses and so on. Consent, you have to be very clear with your patient how many you've done, why you're choosing these approaches, and experience and expertise are key. So we all know about the diffusion of innovation model, but the only thing I'd say is don't think about everything as a nail if you have a hammer. And with that, I'd like to just pretty much close by thanking you all, of course, inviting you to our course that we run every year. And then if there are any questions, I'd be delighted to take them. And I hope I haven't overrun.
Okay, thank you very much, Professor Zebian. Excellent presentation, really great presentation. You are a master of endoscopic tumors intraventricular surgery. So thank you very much. I really enjoy your experience. But I have some questions. If you, what's the limit of the size of the tumor, in your opinion? No limit or limit, maybe 3 millimeters, 2 millimeters, 4 millimeters. What's your opinion? The limit for the endoscopic surgery, pure endoscopic.
Yeah, absolutely. It's difficult to say. I'd just like to thank you, Professor Sofianov. I think one of my first publications was a humble letter to the editor in response to your experience and that of Mark Swaydan on choroid plexus papillomas. So I learned from a lot of you guys, including yourself. I think at the moment,
thank you.
I think at the moment, 3 to 4 centimeters, you can do that operation depending on the consistency. Once it gets to 4, 5, 6 centimeters, you are talking, and depending on what it's stuck to, and if it's hemorrhagic or not, then you're talking about a challenge that maybe you're just trying to prove a point at the moment with the instrumentation that we have, rather than really doing a good operation. So I would say 3 to 4. It's a soft limit, but 3 to 4. Depending on the type of tumor consistency and whether it's hemorrhagic or not.
Okay. Another question: what's your opinion about the portal system? You use only monoportal technique. Maybe possible to use 2 portal, 3 portal. It's maybe easy to disconnect fornix, for example, to open the third ventricle. If you introduce second port, for example, why you why do you not use second or third port?
It's an excellent question, especially considering for the spinal pathology that I'm doing endoscopic.
It's pure endoscopic transventricular tumor surgery.
No, absolutely. But I found the biportal for the spine easier. Yet for the ventricles, I was thinking about monoportal, but biportal. But so far, I think I've managed to do it all with a single port. We were working on developing through a single port, just a way of introducing instrumentation so that you can triangulate a bit better. Whether we move fully to biportal, I'm interested to see. Have you got experience with biportal, and would you recommend going in that direction?
Of course. I have a lot of multiportal approach, because I see your cases, for example, choroid plexus cases, big cases, but you go through the tumor, yeah. But if you prepare plan before surgery, so if you put second port just immediately the vascular peduncle, if you walk in the vascular peduncle at first, this kind of surgery much easier and much bloodless. Okay.
Yeah, it's certainly.
I think for you a lot of work thinking about this. And another Why you use only ultrasonic? Because now we have a lot of other devices for the tumor removal, for example, laser, Nika, and so on. I use a lot
I
of.
use the Nico. I use the Nico as well.
Okay.
Yeah, I do.
Use, for example, a lot of laser for this
Yes.
kind of surgery. Laser is because it's detached surgery. It's very useful for bloodless surgery. It's very useful. Vaporization, very simple surgery now.
I fully agree, and I think Professor Chinali always showed us his experience with laser use, and I found a laser that we'll probably end up using in the future. But I think so far it's just been limitations.
Because ultrasonic is blood. If you use ultrasonic, it's a lot of blood, so it's a little bit difficult. But if you use laser, this is a bloodless surgery. So next week, together with Chinali, we published our series about intraventricular laser and ultrasonic in Genius. So maybe next week. Yeah, we print our Okay.
I look forward to it.
Okay, thank you very much.
Thank you.
Congratulations.
Congratulations to all of you. And it has been a beautiful session, tremendous session with all the esteemed speakers. And thank you once again. I think, Albert, if you agree that it's time to move forward to the next session, because Professor Sami is waiting for us, and we can't wait to hear him. And thank you very much to Professor Sami once again. He's a giant, and we have more than 500 people waiting for him. Okay, so
thank you for webinar. Very interesting. Very interesting. Thank you very much.
Yeah, it was great, really.